You're welcome to my channel. Thanks for visiting. Please remember to subscribe if you haven't. But if you have subscribed and visiting again, I'm saying a big thank you. Without further ado, let's go straight to the topic of the day. The plasma and its components. How can we transfuse? Under what condition or conditions? Let's go. Okay, let's check this sketch out. I'm not a good artist, just bear with me and get the message that I'm trying to pass across. If a blood sample is taken and put in a tube, if it is centrifuged, later on you are going to find this. The lowermost parts will be red blood cells, that's about 45%. The uppermost parts will be plasma, and that will be the largest proportion. In between the plasma and the red blood cell will be the buffer coat. That will be very, very small, but pretty important. These will contain the leukocytes and the platelets, and it's just about 1%. Before delving deeper into the plasma and its components, let me remind you that I have a separate and full presentation on blood product transfusion, A to Z. There I've explained everything that we need to do and how we're going to do it when it comes to all blood products. I mean, all blood products transfusion. It's about 2 hours, 55 minutes. So if you want to, get a broader knowledge about all blood product transfusion vis-a-vis the plasma, the platelets, the leukocytes, packed red blood cells, and so on, you can just click on this very link. But because not many people will be able to sit down for 2 hours, 55 minutes, that is why I brought this separate presentation on plasma out here. Okay, I think you can remember the sketch that I've shown you just a while ago, right? Okay, from the same blood sample where you're going to find the red blood cells, the buffer coat, then you find the plasma. The plasma is the largest portion, right? That will contain water, ions, gases, digested food particles, some call it nutrient molecules, and proteins. The proteins could be antibodies, coagulation factors, albumin, fibrinogen, and immunoglobulins. All will be found in the plasma. Plasma can be obtained from whole blood donations, like the sketch I've shown you, right? Or through apheresis. Preferably, we will be taking plasma from male donors only. It's not that we don't like female donors. No, kudos to all female donors worldwide, but to prevent transfusion-related acute lung injury, we will rather use male donors' plasma. Why that? Let me explain further. The trouble with pregnancy and possibility of alloimmunization has forced our hands to this. The reason is that inflammatory cells will be present in the lungs, and when there's inflammatory cells, that will lead to accumulation of fluid. And when there's accumulation of fluid in the lungs, that will lead to dyspnea, shortness of breath, cough, and so on. And that is transfusion-related acute lung injury. If you want to know more about pregnancy and resource problem and alloimmunization, you can click on this very link. This issue became a big problem in the past. The brilliant scientists from United Kingdom, blood donation experts, first took the initiative in those days that, we are done with plasma from female donors. We will restrict plasma donation to male donors only, because that will prevent transfusion-related acute lung injury. Well, expectedly so, that was not, widely accepted. Immediately it was published. So many people reacted to that as if it's a kind of discrimination. No. Later on, other scientists from other parts of the world, advanced countries, they pick a lot of sense in what the scientists in United Kingdom were doing. And years after, all of them, they have now adopted the system embarked upon by the British scientists, and they've been restricting donation of plasma to males only, just because we don't want more transfusion-related acute lung injury. Okay, ABO matching will be required here, and it will be appropriate to have resource matching done also. The transfusion should be based on ABO compatibility. However, that may not be the case under certain situations. When would that be? Let's go. With compatibility and appropriate transfusion, the ideal transfusion will be to give plasma, like fresh frozen plasma or cryoprecipitate, to only those who will match the ABO group, like the way we do by transfusing packed red blood. But sometimes we are forced into a corner when that compatibility becomes a difficult thing and we need to save that life. Then if we are going to use only fresh frozen plasma or cryoprecipitate, we can then make use of the following. But as a disclaimer, please contact your hematologist or your blood transfusion expert in your jurisdiction. Okay? So, O can take cryoprecipitate or fresh frozen plasma from O, A, B, and AB, but resource compatibility must also be taken into account. For example, on no account are we going to transfuse either fresh frozen plasma or cryoprecipitate with resource positive to any female of childbearing age, even younger ones that are resource negative. So any female, so in fact some authorities will put it any female less than 50, you don't do that. You don't transfuse resource positive plasma components if they are resource negative. So you can give AB to AB, remember the resource. A can take A and AB, remember the resource. B can take B and AB, remember the resource compatibility. So in summary, when we are forced to a corner and compatibility becomes a problem, discuss with your hematologist, discuss with your blood transfusion expert, discuss with other colleagues around, then you can make use of the following as fresh frozen plasma or cryoprecipitate. When do we need plasma? In other words, what are the indications? Okay, when INR is greater than 1.5, meaning it's tending towards bleeding, right? When INR is low, it's tending towards clot formation, right? INR or PT is the same, right? Remember, we have what is known as vitamin K dependent clotting factors. They are factors 2, 7, 9, and 10, produced in the liver. Actually, all clotting factors are produced in the liver, except 2. The 2 that will not be produced in the liver will be von Willebrand factor and factor 8. So when there's decreased factors 2, 7, 9, and 10, we need plasma. When someone is on anticoagulant, but he or she needs surgery, we need plasma. When there's active bleeding, we need plasma. Still on indications, in disseminated intravascular coagulopathy, but we must not get down to the root and treat the cause, like sepsis. When we embark on massive transfusion and we are faced with complications like bleeding due to that, remember, we don't need massive transfusion anymore, except there's active bleeding and you must, replace appropriately. In replacement fluid for apheresis, we can make use of plasma. Irradiation is not that required, and why that? There won't be transfusion-associated graft versus host disease. Still on indications, when we are faced with warfarin toxicity, particularly with individuals already having intracranial hemorrhage, and we need reversal of the same, we use plasma. When someone is on warfarin and he or she needs acute major surgery, then we make use of plasma components. Still on indications, in the face of hereditary angioedema, you can make use of plasma. You can see that I have about 4 different links here. I have full presentation on hereditary angioedema already published. 1. I combine both hereditary angioedema and acquired angioedema. Then hereditary angioedema types 1, 2, and 3 already published. So you can click on this link. Now, plasma derivatives. An example will include human albumin solution. Here, there will be no ABO group antibodies, no clotting factors, no need of cross-matching, but we must be extremely careful. Human albumin solution can be associated with very, very severe hypersensitivity. Must be extremely careful. So human albumin solution is available as 4.5 to 5%, and that will be isotonic. We will need this strength for plasma replacement when we are dealing with burns, pancreatitis, trauma, or in plasma exchange. Please take note of this, 4.5 to 5%. That is the strength I'm talking about now. I have higher strength. Let's go. Okay, remember, I've just told you that you should take note of the strength of HAS as 4.5 to 5 as being isotonic, and I've given you what we use it for, right? Now, higher strength, 20 to 25%, is hypertonic. And we will need this hypertonic solution when we are faced with the need to initiate diuresis in hypoalbuminemia. Okay? So you discovered your fluid in and out is not giving you any reasonable value. I mean, you are sending in fluid, but you are not getting appreciable fluid out. Then you can initiate diuresis when there is hypoalbuminemia and you are dealing with liver cirrhosis, nephrotic syndrome, using HAS of this strength. Also, when there is portal hypertension, also in liver cirrhosis, right, and you have tapped a large volume of the ascites, then you can make use of this, higher strength hypertonic human albumin solution. In newborn, with exchange blood transfusion for hyperbilirubinemia, you can get this ready. Okay, fresh frozen plasma. Well, it will be fresh when the sample was taken, but then 3 years after we are still using it. Okay, it will be frozen at -24 or 26 degrees Celsius. Many people will put it as -25 degrees Celsius. Now in between, right? Can be kept for as long as 3 years. Helpful in the face of reversal of anticoagulants effects, and it contains clotting factors. FFP must be taught. Then I asked the question, and I want someone to supply the answer. Who will use it before being taught? No one, of course. Then, after being taught, must be stored at 4 degrees Celsius for only 1 day. Remember, when it is frozen at -25 degrees Celsius, could be like that for 3 years, 36 months. But immediately it has been thawed, then you don't keep it for -25 degrees Celsius anymore, but 4 degrees Celsius, and not for 3 years anymore, but only 1 day, 24 hours. It is going to be useful for a single dose alone. What are the possible indications for the use of FFP? When we are battling with clotting factors deficiencies, probably due to trouble in the liver, meaning liver disease, particularly chronic liver disease like liver cirrhosis, or there is need for liver transplantation, and the individual is undergoing that, or there is cardiac surgery, will likely make use of FFP. Also in the face of disseminated intravascular coagulopathy, that we must treat the cause. Then when we are faced with factor V deficiency, plasma exchange in thrombotic thrombocytopenic purpura, warfarin reversal. But for the purpose of warfarin reversal, FFP is no longer gaining ground. Why that? We have alternative that is doing a better job, and that is Prothrombin complex. It's more effective as the antidote to warfarin. So, in warfarin reversal, less of FFP, more of Prothrombin complex concentrate. FFP can lead to a very severe allergic reaction, so we must be extremely careful. The European Union is so concerned about the variant Creutzfeldt-Jakob disease, so they are always working to have prime-reduced version of FFP. They do use Medellin Blue process to treat parts from low CJD countries. Some FFP are solvent detergent treated, for example, Otaplast, that could be stored for 4 years at -18 degrees Celsius. Now, cryoprecipitate. We can obtain cryoprecipitate after thawing fresh frozen plasma and is being kept at 4 degrees Celsius. What are the possible indications for cryoprecipitate? Number 1, consumptive coagulopathy. 2, massive bleeding or bleeding related to the use of thrombolytic agent. Example of thrombolytic agent here would be recombinant tissue plasminogen activator. Also, when we are faced with low level of fibrinogen or dysfibrinogenemia. In the face of von Willebrand disease or hemophilia A, also in factor 13 deficiency. What are the possible contraindications to the use of cryoprecipitate? Sepsis treatment, meaning it is not allowed to be used for this purpose. Also, as fibrin glue preparation, we cannot use cryoprecipitate for that purpose. Medicine is not static, it is dynamic. All we are doing is just give exactly what the patient needs and not giving them excess that will give them more trouble. We don't use whole blood for transfusion anymore, except under a few conditions. Okay, that's number one. Number two, we say, okay, we can use fresh frozen plasma. Now we have reached third stage. We don't even want the fresh frozen plasma. We want something lesser, less volume. Then we end up with cryoprecipitate. That will contain fibrinogen, von Willebrand factor, and factor 8. So in unit, it's going to help in dealing with factors 8 and 13 deficiency. Also in von Willebrand disease and congenital fibrinogen deficiency or defibrinogenemia. Now, clotting factor concentrate. Remember, I made mention of Prothrombin complex concentrate while talking about the use of FFP in warfarin reversal. But PCC will do a better job. Now, PCC is useful in liver failure with coagulopathy in warfarin overdose, better than fresh frozen plasma. PCC will contain factors 2, 7, 9, and 10. They are vitamin K dependent clotting factors. PCC is better to reverse warfarin toxicity or overdose than FFP. There's less risk of cardiac overload, less allergic reactions, and less thrombosis formation. Now, immunoglobulins. We can obtain these from large pools of donor plasma. And when we get that, we'll go through two different routes. It depends on what we want to achieve, right? We can give it intramuscularly when we need a small quantity to handle hepatitis A, measles, and rubella. But when we need a large quantity, it's the same immunoglobulins, right? When we need a large volume, then that is a high dose, right? We'll go intravenous. So intravenous immunoglobulin will be high dose for the replacement of immunoglobulin deficiencies and the treatment of autoimmune diseases like Kawasaki disease. Now, all those autoimmune diseases like Graves' disease, Hashimoto's thyroiditis, Crohn's disease, rheumatoid arthritis, systemic lupus erythematosus, and the list goes on. Lastly, we can make use of specific immunoglobulin from selected donor, and that will be with higher antibody levels to the target treatment. For example, in hepatitis B, rabies, tetanus, and prevention of rhesus D aluminization in pregnancy. Remember, I've dropped a link that can take you to full presentation on rhesus D aluminization in pregnancy. And finally, please, if you have the time, if you want to know more about transfusion of all blood products A to Z, please kindly click on this very link. With that, I've come to the end of this short presentation. I've just taken this out of the full presentation as per blood product transfusion. This link will take you to 2 hours 55 minutes on all blood products transfusion. But you are going to spend 24 minutes right now to know everything you need to know about plasma transfusion. Thanks for listening. Remember to share this. Remember to subscribe to my channel. I appreciate it.